So make sure you're tight, flush it with saline, get all the air bubbles out, and then connect your cables. So if we have everything connected and we're getting ready to do our zero-hour monitoring, we're going to basically have our line plugged in, our cables plugged in. This is going to be our static axis. And we're going to turn this off to the patient. And the easiest way to remember which one's the patient is this tubing is a lot more rigid, and the syringe is right here. So this gets off the patient. You have this open atmosphere, and you hit 0 on your monitor, and that's when you'll see a little 0 pop up on your monitor. And once that's zeroed, flip this back, flush it, little square wave, and then you'll get your arterial reading. It might take a couple seconds for your pressure to come up, but then you'll have your art-line waveform. And depending on your monitors, some of them will automatically identify the range. That's another thing to consider. The monitors is similar to like your heart rate monitor. It will default to like 100 to 60 or something like that, or whatever if you're those things. So make sure you adjust your range on your monitor to get your blood pressure in the right field. Or else your waveform might like be this tall if your blood pressure range on your monitor is set to 50 to 200. You know, if you set it to like 150 to 70, then your waveform will be a lot appropriate size. So, if you're going to draw blood, there's these nice little ports on here. We at the hospital have little adapters that can plug into this. Like I mentioned earlier, if you're drawing blood off a central line, draw 10 mils off, waste it, and then use whatever sample you get from that as far as your lab samples or something. This, you automatically draw back. It's going to keep the blood in here, so that's your 10 mil waste, and then you can draw right off here. I always would turn this just so I don't get the waste blood. You're going to get clean blood right from the artery. It's an art line. Once you're done, don't forget to turn this back. Not that I've ever done that before. But as soon as you get back to looking at your waveform, it'll just be a flat line. That's another reason why I lock this. Is because if I lock this when I draw my blood sample back and draw my labs, when I go out to look at my monitor, it's just going to be a flat line because all it's reading is this pressure to right here. If I keep this open, it's still going to sense that aortic waveform. But I just got a big old syringe full of blood, and what's going to happen to it over a period of time? It's going to be a big old clot. So if I turn this, if I draw blood back, then it's going to remind me not only on my monitor as a backup, but then I can see that, hey, I got to fix this, and then I can just push the blood back in, which is kind of nice. So that's a transducer setup. Pass it over. If you haven't seen that before. Central line. This is just a 2-lumen central line. Actually, yeah. With this thing, you can see there's a proximal is an 18 gauge, the distal is a 14 gauge. But again, look at your distance. If I got a 14 gauge distal port, the length of that tubing that it's got to flow through as far as fluids. If I have a 14 gauge and AC, it's this long. So larger vessel, less lumen to travel through, faster flow. So that's just a 2-lumen central line. And then there's a 3-lumen. There's a triple lumen. They actually make a 4, I think, too. And here's a PICC line. If you ever see these purple things, if you ever see like a purple catheter, this is a 17 gauge PICC. It's a power PICC. Patients that'll have infuser ports, they'll have like power infuser ports or whatever. You guys know what that means? Basically, if they go to CT scan and they need to push a bunch of fluid quickly, like the dye, the contrast dye, they have to push it really fast, and so it has to handle that flow, that rapid flow. If they don't have a power PICC, they're not able to use like contrast diatherm. With this, they can. So most, I think all the PICCs at Mercy now have power. Most of them, I think everywhere do. The infuser ports, they're shaped like a triangle, so they can actually tell on X-ray if they don't know if it's a power port or not, if they can handle the flow. So the nice thing about a PICC is what they do is when they place these, they measure them. So they basically measure anatomy when they size these. Have you ever seen a PICC placed? And then they trim it. So this kind of gives you a nice idea of what the lumen size of a PICC line looks like as far as just identifying the volume too. So, yeah. You guys talked about pacemakers this morning, didn't you? There's a temporary pacer. There's a cable, what it looks like. So, gets plugged into the box, and then we're at Mercy Ambulance one night doing training, and they just happened to transport a temporary pacer from like West Lakes to Maine or something like that, and they had the box still. So we were doing like the same lecture, and we were messing around with the, looking up to the pacer and trying to shock people. I don't know if they got shocked or not, but they were messing around with it. So that's just a temporary pacer, really what that looks like. Those little brass ends get plugged into the box, and
that's the transvenous pacer.
yeah. Yeah, don't try to do that externally, it won't work. Just saying, stick with the pads. Heart failure management. So, balloon pumps and such. CardioSave, this is, Mackay is the manufacturer of the balloon pumps we use at Mercy and pretty much predominantly throughout Iowa. I'm only going to talk a little bit about who's ever taken care of and transported a balloon pump patient? Anybody? No? No? Anyone? No? Okay. So, yeah, there's some objectives.
We called the perfusionist to go with us.
Yeah, perfusionist, yep. They used to, when I first started at CCU, the perfusionists would come up every time they'd have a balloon pump from Cath Lab to CCU. Then they realized they didn't do anything during the transport. They usually weren't even there in the Cath Lab when they were put in. So they get called in to basically transport a balloon pump. And they didn't know anything about the patient. So they stopped coming. And they just let the nurses take care of it. So when is someone maybe going to get a balloon pump? All of these things. Septic shock, I don't recall ever seeing someone with septic shock ever getting a balloon pump, but I suppose. Acute MI typically, anytime where we need to wean from bypass, a lot of patients after open heart surgery will have a balloon pump in, and a lot of times that's just to help decrease the afterload. So we're going to talk about that here in a moment. So indications, here's all your indications. Cardiogenic shock, cath lab support are pretty much your typical cases when they're going to do that. More acute MI complications. So they have a really bad infarct and they needed some assistance afterwards. So cardiogenic shock incidence, STEMIs 5 to 8%. Yeah, there's probably more of that. Approximately 50% monitoring. So hemodynamic parameters. What are we looking at as far as cardiogenic shock when someone's going to get a balloon pump placed? Systolics in the less than 80s, MAPS less than 30s. And this is where in the unit, especially with patients that have a balloon pump in, we don't really look at systolic blood pressure all that much. We look more at the mean arterial pressure and the augmented pressure on the balloon pump. The main reason for that is the mean arterial pressure gives us a better understanding as how well we're perfusing our vital organs, our brain, our kidneys, all the stuff that we need to survive. So we look at the mean arterial pressure a lot more than we do the systolic blood pressure. Output index as well, and then the end-diastolic pressure greater than 18. Presence cardiogenic shock, yes. This is all terminology that physicians look at in regards to stuff. Contraindications. So when wouldn't we put a balloon pump in? If someone's in cardiogenic shock, things that we look at is if their vasculature is terrible. So if they have really poor iliac disease or peripheral vascular disease where they can't actually get the catheter in place, because you're essentially signing a balloon, a very thin membrane balloon into a vessel. If there's a bunch of calcification or tortuous vessels and they can't get that catheter placed, well, we're not going to put it in. And a lot of times they can identify that just by doing angiography. They can shoot dye into the vasculatures and look at the arteries and identify if they think they can get a balloon pump in there, a balloon in there or not. If they have aortic insufficiency, whoops. So if their aortic valve doesn't function properly, what do we need to do with the balloon pump? When the balloon is inflating, it's pushing pressure back on the aortic valve. So if the aortic valve is crap, we're not going to maximize the benefit, and we're going to do what? Nothing but increase our end-diastolic volume. So that whole EF thing that we're trying to improve, we're going to compromise that because we're just pushing more blood back into the left ventricle. Aortic aneurysm, sure. Someone has an MI and we shove a balloon in there and break open an aortic aneurysm. Hey, call the vascular guy. That's just another problem, so we don't do that. So this is one thing I kind of like about this whole little presentation is supply and demand, right? And we need to maintain our volume oxygen delivery. So oxygen supply, we look at our coronary perfusion, our anatomy, diastolic time and pressure, because our coronaries are being filled at what time? Diastole, right? So we're going to maximize that time. Because I always think in the context of someone that has an MI. They're having a heart attack, their coronary artery is occluded because of whatever reason, they're overweight, they smoke, genetics, whatever. But now they've had an MI and they've had tissue damage to the myocardium. So they go to cath lab, get that artery opened up. Now we need to maximize the time frame that we can to perfuse that damaged myocardium. We need to maximize the oxygen delivery to decrease the long-term effects of that infarct. So by doing that, we want to maximize our diastolic time and pressure. Heart rate, we want to monitor that because we want to make sure we're giving delivering the oxygen supply and not increasing the demand. If there's an increased demand for oxygen, what did we talk about earlier? Our heart rate's going to go up. And that's something we're going to do with someone having an MI. You guys all seen this before, normal, and then someone's got a 70% or greater occlusion, that's what gets an MI, blah, blah, blah. Talked about this a little bit when we looked at our waveforms. So our EKG tracing, here's our arc line, our systolic blood pressure, our diacritic notch, and we're filling in our diastolic phase, right? So our coronary arteries are being perfused at that pressure, 60 beats per minute. We increase our phase as far as diastolic fill time. If someone's tachycardic, we talked about this, our fill time is going to be less. So not only is our stroke volume going to be compromised, but also our fill time to our coronary arteries is going to be compromised as well. So we're not maximizing our perfusion to the coronary arteries if someone's tachycardic. Hemoglobin, PA2, we talked about that. Oxygen demand. Yes. Afterload left side resistance, we've talked about this. Preload left side. About that. All right. So when you look at your EKG tracing, kind of mentioned this a little bit, your arterial systole, your ventricular systole, and your diastole. So we see our ventricular ejection pressure here, our systolic blood pressure is here, and our diastolic pressure is here. So our ventricular fill time is in this area. We want to maximize that potential, right? That's what a balloon pump is going to help with. We identified this a little bit ago, our diacritic notch, and that indicates our aortic valve closing. So this gives us our mean arterial pressure and our diastolic fill time, which is also the pressure that our coronary arteries are being perfused at, right? Like that, right coronary perfusion, diastole. Here's just a close-up of your aortic root, your right coronary artery, and left main coronary artery. So we're having kind of a little side conversation in regards to aortic aneurysms or something of that nature, and kind of off subject a little bit. But if someone has an aortic aneurysm where they dissect right here near the aortic root, the ascending aorta, right off the base of the heart, you can potentially see EKG changes consistent with someone having a heart attack because of the close proximity of the coronary arteries. I recall one such case where they thought it was an inferior MI, did the whole level 1 stuff that you normally would do, or cardiac alert stuff that you normally do. Dr. Randy goes in there, puts a catheter in here, tries to shoot the coronary arteries, and then just sees all the blood fill up over here outside the aortic root. He's like, well, we're done. There's nothing I can do here. Because even if you got a cardiothoracic surgeon in there and everything else, they would have to be like basically prepping this person at that time because they're going to bleed out. This dissection and this aneurysm's right here. There's nothing they can do to fix it. So little things like that, it's kind of always assess your patient, try to do the whole differential as to what's going on. Size of place, there's 3 different sizes. We basically, one size is commonly used. When they're placing these catheters, they want it about 1 centimeter, 2 centimeters distal to the left subclavian artery. So you'll see the tip, it sits normally right on an x-ray. I've never been able to identify the tip of one of these things on an x-ray. I struggle with it. Angiography, if they're sitting in the cath lab, I can kind of see it. It's a little bit easier because it's close up. It's much closer to the anatomy. But other than that, it's hard to see. But the key thing is this has got to be distal to the subclavian artery, the proximal to the renal arteries, above the renal arteries. So what do you think as far as complication-wise could happen if this balloon's not in the right spot? That's a good, no blood flow to the kidneys. Is that a bad thing? Yeah, that's a bad thing. How are we going to identify that? In the pre-hospital setting, that's where you got to kind of not stop thinking 911 and start thinking critical care transport. How would we identify that? What's that?
Depending if they've got Foley in or something, just watch their output.
Yeah, urine output. Absolutely, urine output's huge. Unit nurses love to know how much people pee because it gives us an idea of how their kidneys are functioning. It also gives us how well our kidneys are perfusing. If someone's in really bad shock state, they'll shut down renal perfusion and then stop making urine. So yeah, we're going to look at urine output. We want to see, 30 mils per hour, ideally, at least. How are we going to know if it's too far up?
Starts with a P, ends with a pulse.
Pulse. Check radial pulses. Anytime someone has invasive lines in, I mentioned it earlier with like the femoral artery lines, checking distal pulses, make sure you're checking pulses. All 4. Your bilateral radial, bilateral pedal, post-tib, whatever. The balloon pumps at the hospital have a Doppler attached to them for a reason, so they can check pulses. If you have a cardiogenic shock patient that has a balloon pump in, you probably won't be able to palpate pulses. You might be able to. Your best bet is Doppler. So check your left radial pulse. Check your right radial pulse. I don't feel anything here, but I got a nice good one on the right side. Okay, where the heck is this balloon pump? Am I seeing it? Am I losing pulse as the balloon's inflating? Those little things you can watch and monitor. Because if that migrates too far up, now we're causing limb ischemia to the left arm. Because we're not perfusing the left arm. Here's the chest x-ray. Yeah, you can't hardly see it, but you can. So like I said, they got it circled here. Yeah, there's the tip. Whatever. It's easier on angiography to see it. So, theory of cultural pulsation. So what happens with the balloon pump? If we have a decreased oxygen supply, our pump's crap. Got a heart attack, EF is 10%, 15%, whatever. But we have an increased demand because of having a heart attack. How do we fix this? Well, we try to maintain homeostasis by balancing it out. The increased supplies oxygen to the myocardium. So when that balloon inflates, because we identified that our coronaries are perfused at diastole, the balloon inflates at diastole. So when that aortic valve closes at our diacritic notch, the balloon inflates. So it does 2 things. It increases the retrograde blood flow to the coronary arteries, perfusing the coronary arteries better. And then it's also inflated until the next ventricular contraction. So now that whole systemic vascular resistance that our heart's got to pump against, it's not pumping against that whole aortic. It's just going up to that balloon. So it's recognizing that just that up to that balloon is that resistance. So it's decreasing the resistance that the heart has to pump against. Make sense? So less resistance to pump against. Oh, a lot of transitions. Damn it. It's going to talk about all the stuff that I just said. How it works. Deflation. So decreases the demand for oxygen by the left ventricle. The balloon deflates just prior to systole. So, like I said, rapid decrease in aortic pressure. Decreases the afterload, decreases the cardiac workload, and increases cardiac output. All good things. This is just a nice little video that kind of shows you what's happening. You can see the coronaries being perfused when the balloon inflates. Isn't that fun? Effects of balloon pump therapy. So we increase our coronary perfusion, we increase our cardiac output, we decrease our heart rate, we decrease our systemic vascular resistance, we decrease our systolic blood pressure. Oh, wait a minute. Why are we decreasing systolic blood pressure? Person just had a heart attack. Why do we want to dump their blood pressure?
You want to decrease in the preload to affect the afterload, right? Just puts less work on the pump.
Less work on the pump. Exactly. That's right. So if we decrease our afterload, our preload should stay the same because the volume should still be coming in, right? But we're going to decrease the afterload because we want to decrease or maximize our cardiac output by decreasing our heart rate. So our systolic blood pressure, by dumping it, we're decreasing the workload on the heart. The heart doesn't have to work as hard, which is the goal. Diastolic pressure increases, and diastolic pressure decreases. Our mean arterial pressure increases. Again, that mean arterial pressure is the pressure that's perfusing the vital organs, right? So if we can increase our mean arterial pressure and decrease our systolic blood pressure, that's a win-win. The heart's not having to work as hard, but we're still improving our perfusion to our vital organs, right? Oh, questions? You already, balloon plates when they How about this one? Run through is kind of quick, so. Deflates just before what? Air valve does what? Deflates? So what's the balloon got to do before, or what's got to happen before the balloon deflates? Or right as it? The aortic valve opens, right? So the balloon's going to deflate right as the aortic valve opens. Balloon pipe is inflated during which phase of the cardiac cycle? Diastole. Yep. Maybe. Maybe not. There we go. Deflated during which phase of the cardiac cycle? Systole. It's kind of easy. It's like true pulse, isn't it? Main benefit of inflation is to increase myocardial oxygen supply. So to increase our perfusion to the myocardium. Main benefit of inflation is decrease myocardial demand. So the ventricle doesn't have to work as hard, so we're decreasing the demand. Timing and triggers. Timing errors, timing stuff like this. Okay. So the beautiful thing about new balloon pumps versus the ones that I was taught on when I first started working in the unit is they time themselves. Thank God. It is so much easier to time balloon pumps. But what we're looking at, oops, I keep doing that, is when we time it, we got to look for that diacrotic notch. Remember how I said that diacrotic notch is going to be important later? This indicates when our aortic valve closes. So what do we want to take place from the balloon side of it? We want it to inflate at that time. All right? So we got to watch for the diacrotic notch when it inflates. So this is going to be kind of tricky to see on here, and hopefully there's a better picture in your book. But occurs at diacrotic notch, you'll see this V shape right here. So this is an unassisted beat. So this is unassisted. It's your normal aortic waveform. Here we have the balloon inflating. So here's our augmented pressure diastole. And this is an assisted systolic beat. So the balloon inflates at the diacrotic notch, and then it deflates right before the next systolic contraction, reducing the end-diastolic pressure. Let's see if there's a better picture. A little close up. I don't know if they'll have test questions like this on your book, but this is a common one they like to do. They like to do this little waveform and say, okay, label these points. So if you look at it, here's your diacrotic notch. I always try to go back to where's my unassisted beat? Normal arterial waveform, diacrotic notch, so I know the next one, okay, here's where we got a C, so a diacrotic notch, and this is where our balloon is inflating. Here's our augmented diastolic pressure. And this is our, is going to be our assisted end diastolic pressure. So our diastolic augmented, and this is the assisted end, and our assisted systolic pressure. So if you take a line right through here, it's kind of hard to see on this. If we had the balloon pump, we can actually set a line. There's like a little line you can trim it. You can put a flat line across there, and you can see how your systolic blood pressure drops with the assisted beats. And so we're decreasing our blood pressure, but our mean is actually maintaining or maybe a little bit higher. There's another example. So here you can actually put numbers to it. So our systolic pressure is 102. Our augmentative pressure is 116. So we're augmenting our diastolic pressure. So we're augmenting the perfusion to our coronary arteries to 116 millimeters of mercury versus 52 millimeters of mercury. Our assisted systolic beat is now 98, which that's pretty minimal, really. If you have a cardiogenic shock patient of this nature, it's not uncommon for, if you have the pump turned off, their heart rate could be like 110 beats a minute, and their blood pressure will jump up to 100 systolic. As soon as you turn the pump on, like a 1-to-1 ratio, so it inflates and deflates and assists with every beat, their pressure will drop down into the 90s or lower, and their heart rate will drop 10 to 20 beats as well. Very, very common for that to happen with someone that's in cardiogenic shock. Or even more so if they're on cardiogenic shock and have pressors, a lot of times we'll leave their systolic pressure in the 70s. We're again looking at their mean pressure and the augmentative pressure. If their mean is greater than 65, we're good with that. And what are we augmenting? If we're augmenting to the 100s, perfect. They got a good blood pressure. We don't really pay attention to the systolic blood pressure. So when we started using the balloon pump in flight for transport, we actually, our balloon pump protocols are completely based off of mean arterial pressure. We don't even look at the systolic. Because if someone's in cardiogenic shock and they're on vasopressors, their systolic blood pressure is going to be low and we want to titrate for the mean. So, timing wise, this is what we're looking at. We're looking to make sure our inflation time is right at the diacrotic notch and we're deflating before we get the next systolic contraction. Mean arterial pressure, we talked about that. Here's a 1-to-1 frequency. And so this is where it's really, really hard to time a balloon pump. Because you're sitting there trying to think, all right, well, all these are assisted, so it's like, am I deflating at the right time? Am I too early, too late? How do I tell? It's kind of hard to tell. So a lot of times you'll have to switch it to a 1-to-2 frequency. And by that I mean, there's 3 different ways you can identify or set to assist with each beat. It's either 1-to-1, 1-to-2, or 1-to-3. So it's either other beat, every other, or every third. So kind of self-explanatory. 1-to-2, same kind of thing, what I've been showing you. And then 1-to-3. Typically, if it's in 1-to-3 mode, they're weaning the patient off the balloon pump. It's to the point where they don't need the assistance, and they're letting the patient do more of the work themselves, as opposed to the balloon pump helping with their afterload. So that's what it's looking at. Timing errors. So if we inflate too early, this can be bad, because if we inflate prior to the diacrotic notch, we encroach on the augmentation. But also what we're going to basically do, if you think about it, we're increasing the pressure in the left ventricle. Because if we inflate before the aortic valve is closed, the ventricle is contracting, the balloon inflates, now it's pushing all that blood back into the left ventricle. So we're increasing the pressure in the left ventricle, completely defeating the whole purpose of what we're trying to do. Aortic regurgitation, increase oxygen demand, myocardial oxygen demand. So, and that's always identified because here's our diacrotic notch. So we should be inflating here, but we inflated way up here. So, nice thing about the newer balloon pumps, it doesn't let that happen. You can have it happen. I mean, it's a computer, and you can override the computer, just like you can turn the alarms off on your monitor. You can circumvent the system, but I'll show you how not to do that with some of the pumps that we use. Too late, so it inflated too late. So here's our diacrotic notch. We inflate down here. See how much our diastolic augmentation didn't do anything. So we defeat the whole purpose. We're not maximizing our augmentation pressures, so it's not maximizing the benefit. Premature deflation. So we should be deflating closer to the next systolic point. It's deflating up here. So our assisted end diastolic pressure isn't lowered as much as it probably could be. So we're again not augmenting our diastolic pressure as best as possible. Decrease of coronary perfusion, kind of self-explanatory. Late deflation. So now we're deflating after the aortic valve is open. So the ventricle is contracting and it's basically just pushing up against the balloon. So we're not confusing the body. Triggers. So how does the balloon know when to inflate, deflate? EKG. It's going to be a lot of times based on the EKG tracing. Your primary trigger is going to be the EKG. The alternate trigger is going to be pressure. It's an art line. It has a pressure in there. It can identify when the aortic valve opens and closes. It can identify those pressures changes, and so it knows when to inflate, deflate. But a lot of times it's going to be based off EKG, which is a nice thing. Yeah.
So if you, is there a particular lead that it reads that it goes by? Does it go by all leads available on here?
Yeah, so you'll have a 5-lead hooked up, so you can scroll through and pick whatever lead. It typically defaults to lead 2, like everything does.
Artifact's not going to mess it up at all or anything?
If it does, if they do have a lot of artifact, it'll automatically trick over to pressure. This is a cardio save, so it'll automatically default to EKG as a trigger. It has pressure. These other things that are there, they're there, but you won't use them. And I say that in that. Well, I shouldn't say. Yeah, you probably won't use them. The only might use internal there and LVAD, but won't touch base on that. EKG trigger. So if they have a pacer, which is not uncommon for someone to have a temporary pacemaker and have a balloon pump, it'll identify that. It can pick that up. Looks for the R wave to trigger off of. Recommended for your arrhythmias, pace rhythms as well. So EKG as your trigger is your primary one. If it needs to trip to pressure, it will. Pressure trigger, it identifies systolic upstroke. It's a backup. If EKG artifact, if they have a ton of artifact, it's going to flip the pressure. If they go into cardiac arrest, it'll flip to pressure as well. So if you ever have the opportunity to do CPR and someone has a balloon pump, it's a good, or a heart line for that matter, it's a good barometer to know how well your compressions are. Because you'll be able to see real time your pressure as you're doing compressions. It's kind of crazy. So I remember vivid time. What's that? No. So if they're in cardiac arrest, you don't have to shut off the balloon pump or anything. You just leave it on. Don't make any changes to the balloon pump. Just manage the patient. Start doing compressions. Hook up your Lucas device. Defibrillate them. Whatever you need to do. Just leave the pump as is. It'll automatically flip to pressure if you start pushing on their chest. And a lot of times, the best thing to do is take the screen and turn it towards whoever's doing compressions, so you can watch to see how they're doing. Pacer AV. This is, you're not going to use this with. Don't do that. Internal trigger. So I have not seen this done. I suppose it could be done. I'm not going to say it's never going to be done. The internal trigger is balloon inflates and deflates at a set rate of 80 beats per minute. The only time that I could think that we would do this in a transport modality is if someone has an LVAD. Because they don't have the contractility. It's a pulsatile. It's a continuous flow. It's just the pump is just pumping blood. So there's not that aortic valve opening and closing. I mean, they still might have the aortic valve functioning. You might still see it, but it's not going to be enough to identify this. So the balloon pump doesn't know when to inflate, deflate because it's just a continual flow of blood. So that's the only time that I can think where they would do this, or the OR, which we're not going to be in there. So if they have an LVAD, you might have to switch to internal, and then it's just going to inflate, deflate 80 beats per minute. Which, hey, I find it hard to believe that someone would have a balloon pump and an LVAD. I suppose I'm not going to say it couldn't happen because I've seen crazier things happen. Factors affecting diastole, kind of talked about this. Hemodynamics, heart rate, stroke volume, mean arterial pressure. The catheter sheath unfurled position. So if there's a kink in the catheter, it can definitely disrupt your fill time. There's a helium line. If that thing gets kinked, you'll hear the balloon pump get angry. It'll push harder and try to push the helium into the balloon and deflate. Are things you got to watch out for. If there's a balloon pump leak or low helium concentration, if you get the helium line caught in a cotch or something that kinks it or breaks the helium line, yeah, good luck. It's a problem. So this is really important to make sure your lines are secure and everything's safe. Timing. We talked about the inflation deflation. With these pumps, they can set on automatic. It's an automatic R-wave deflate. It knows exactly when to deflate. It's an automatic timing on everything, so you really don't have to adjust everything. There's going to be this little augmentation screen on here. It should always be to max. What that indicates is how much helium is being filled into the balloon. So we're going to maximize the balloon volume, so it should always be dialed up to max. You'll see this little green bar thing on the screen, and it should always be dialed up to max. The only time that I can recall where we turn it down is one of the cardiologists, interventionalists, that was how he liked to wean the balloon pump off. He would just dial this down, dial down the augmentation, which, whatever. Side effects. So limb ischemia, I mentioned this multiple times because this is truly one of the most important things we have to monitor in a transport modality. Just because we're kind of complacent with it. We are. I mean, it's nature we are. We don't check fetal pulses. I don't want to see someone's nasty, stinky feet. But it's something we need to check with if they have a balloon pump in. Bleeding at the insertion site. So this is where if you're transporting a patient with a balloon pump, do your due diligence. Look at that insertion site. If it's a femoral, open it up, look to make sure it's not bleeding. Make sure they don't have a big old hematoma. They can have a retroperitoneal bleed. If they start complaining a lot of back pain during transport, is it kind of positional? Can you slide them a little bit, try to make them a little more comfortable, or is it something that we need to be concerned for a retroperitoneal bleed? Physicians trying to get a needle into an artery, they can pass right through the backside of that artery and still get the sheath in the right spot, so they can be bleeding posteriorly and not know it. So always kind of keep that in the back of your mind, because a lot of times they are anticoagulated. Immobility of the balloon catheter. These things have a stat lock and they clamp down, similar to like that one catheter. If you saw, there's like a little wing area that has 2 holes in it that locks into a stat lock that clamps it into place. So it should be secured on their skin with the tegaderm and everything else on it. But make sure it's good and tight. If they're bleeding from that site, it's not impossible for those stat locks to come off because of the bleeding, the sweat, whatever the case may be, if they're diaphoretic. So really watch those sites and make sure that balloon doesn't migrate. Infection, obviously keep it clean. Aortic dissection, you're not going to fix that. Compartment syndrome, they can get compartment syndrome in their leg because of the decreased blood flow. So if they have poor vasculature and you have this big old sheath in there, it's not huge, it's not as big as like an ECMO sheath, but if they have a sheath in there and it's causing decreased flow to their limb, you can definitely cause some problems. Balloon leak, you're only going to identify that if there's a balloon leak, if the balloon inside the aorta actually starts leaking. How do you think you might be able to identify that? Waveform? Maybe. So if we have the balloon has a leak, which I've never seen happen, doesn't mean I haven't just had it hasn't happened yet to me, but it can. If they have that tortuous vasculature, they have a bunch of plaque or something in their iliac arteries, and they're sliding this balloon in, and it snags it, and they turn it on, and now there's a leak in the balloon, or a hole in the balloon. What we can look for is we can look in the helium line. The helium line is going to be a little thicker lumen. It's a larger lumen than your anything else that's going to be attached as it's going to the pump. look for little rust-colored flakes in the helium line. There's rust-colored flakes inside the tubing. That's basically little blood flakes that have now been distributed back down the line. I say make sure they're internally because anytime they're doing a procedure, it's easy for blood to get splattered about. So make sure you're cleaning it. If it looks like, that might be blood, let's make sure it's not. If it's inside and you start seeing a bunch of little red flakes or rust-colored flakes, that's a good indication they probably have a torn balloon. Also, the pump's gonna be alarming and helium leak and all this other stuff. And there's nothing you can do to fix it. You just shut it off. Just shut it off, and when you get to a facility, they have to discontinue the balloon pump. Thrombocytopenia, the balloons can chop up blood cells pretty well. You just might see a little bit of that, and you can kind of typically see that in your urine. The blood will start getting pink tinged and red blood tinged. What else?
So is that like a 7 French?
Yeah.
Is that,
Yep. Typically it's through a 7 French catheter. Balloon leak. Oh, here you go. Plaque abrasion. Little hole. Stop pump. Notify doc. Remove catheter. Don't pull these things out. You don't want to be ripping stuff out of someone's aorta. We don't get paid enough and don't have good enough insurance to do stuff like that. So let a physician do that. They'll get the gas loss alarm. There's nothing you can do to fix it. Patient assessment. I talked about this. The radial pulse, insertion site, pedal pulses, interlumen flush line pressure waveform, urine output, blood and tubing, corrective action, check position of the pump. Are we going to check? We can't move the balloon, but if you notice these things, they're basically things to watch for and notify. If you see bleeding at the insertion site, what can you do? Hold pressure. Put some pressure on their groin. It's not comfortable. There's a few times where I've had patients in the unit where I'm sitting there with my fist in their groin to try to stop the bleeding. We've had combative patients that have been tossing back and forth and displaced their femoral heart lines or balloon pump, and now there's blood all over the place. So be very, very cognizant of that. Always make sure you're checking the sites. They can bleed out quick. This is a balloon, and I forgot to grab one. I could have brought it one with me. I forgot to. It was upstairs. So the balloon is here, and then you have your helium line. I think there's another picture here. This one is the balloon here, and then you see this orange line. The nice thing about this orange line is a fiber optic catheter. There's a fiber optic line that goes to the tip of this balloon here, and that's what monitors your blood pressure. So the beautiful thing about a fiber optic catheter, which we use, I think all the interventional facilities, with the exception of Marshalltown, if they still have their cath lab open, have the fiber optic catheters. So the nice thing about that is, kind of like with the Heartline where we have to zero it, this you don't have to. It's automatically zero. You just plug it into the pump and it automatically zeroes your catheter, which is awesome. Here's the side of the balloon. This is the CS300. So this is the balloon pumps that we have at Mercy, and I think Methodist has the same ones on that for sure. Helium tank here. This is where our helium line would plug in right here to this port. Our EKG leads will plug in here. And if we had a pressure cable, it'd plug in here. And then there's a fiber optic port as well. That's on the next slide, I think. That's just a close-up. So our helium line plugs in here. There's a little ring that kind of protects this port, and it's as simple just like a catheter tip. It just slides right into that port. There's nothing really fancy to twist it or anything. It just plugs right in. And your EKG leads are here as well. Here's our fiber optic port. This door slides down, and a little fiber optic cable plugs into that. This is kind of hard to see on here, but this is the display panel. So if you go to a facility and have a balloon pump on, here's your standby and start. Basically, if you have a patient that has a fiber optic cable, if everything's hooked up, you plug in the fiber optic line, hook up your EKG leads, and plug it into the port, you hook up your helium line into the side little reservoir, you hit start. That's it. That's all you have to do to get this thing going for a patient. Well, there's a power switch. You should probably turn that on first. But You hit start, it'll take a few minutes to calibrate, it'll zero, you're gonna helium fill, fill and defill, and it'll automatically zero everything. Oops, and it should always be in auto mode. As long as it's in auto mode, it's gonna default to EKG pressure. Here's where we change from 1 to 1 to 1, 1 to 2, 1 to 3.
Did the doctors prescribe what ratio they want? Or
It's
is that
typically always 1 to 1.
okay.
Historically, what could happen is if you think you're tachycardic patients where it's trying to time off their EKG tracing, it can have a hard time doing that. The older models were really bad about timing. The newer models, because the technology is a lot better, it automatically times, and a lot of times it'll be 1 to 1, and you maximize your benefit with the pump. Most important thing to notify here is the alarm mute. If there's an alarm going off, you can hit mute, and there's a help button. On these pumps, the help button will walk you through any alarm that's on there. It'll page by page walk you through the process of how to troubleshoot. That's the nice thing about the balloon pumps. Here's what the screen looks like. So it's in battery use. Lead 2, we got an EKG trigger, heart rate, blood pressure, and this is a 1 to 1 assist, right? We have our nice little square waveform. It looks like a chair, and this is the balloon pump. This is the balloon waveform. So the balloon inflates, deflates, and that's the waveform that's there. Unlike your monitors where you have a systolic blood pressure alarm, this goes off augmented pressure alarm, because that's what we're really trying to maximize with this pump is the augmentation. So you'll see that the augmentation alarm is set to here. It calculates over a 3-minute average what the average diastolic augmentation pressure is, and it reduces 10 millimeters of mercury. So it's basically saying that, hey, we've averaged 116 for 3 minutes, your alarm's going to be 106. And you can adjust that if you need to. But in the unit, we always set it about 10 to 20 below. So if I'm outside the room or down the hall, I'm listening for that to alarm to know that, hey, my pressure's dropping in that room. If we're transporting these patients, what are we doing? Well, we're staring at the screen, so we really don't need to have an alarm. Questions on the balloon pump? That was kind of a quick, 45 minutes review of the balloon pump. Big things to take on with the balloon pump as far as transport-wise. Check your pulses. Watch for bleeding. Watch the catheter, make sure it's secure. If you have little rust-colored flakes or blood in the helium line, shut off your pump. I think your book probably refers to manually inflating and deflating the balloon. The only time you're going to have to do that is if the machine fails. In my 13 plus years of nursing, I've never heard of or seen a balloon pump fail. You can plug these in. They have a battery. The CardioSave has a 90-minute. Each battery, it has 2 batteries, and each of them lasts 90 minutes. Or you can plug it into a 110 outlet. So you can plug this in the back of your ambulance and without an issue and run the pump for as long as the ambulance is running or your inverter keeps up. So helium, there's a little helium gauge over here, and this is like 3/4 of the way full. You could probably run that thing for a month and a half or 2 months continuously without that helium being there. So don't worry about running out of helium. You should be fine if it has that much in there. Lines, pressures. Keep it on EKG, keep it on auto. If it's on auto timing, you're going to be good to go. Won't have any issues. If they go into cardiac arrest, ACLS, don't worry about the pump. One other factor that I didn't mention that I forgot now that I'm sitting here thinking about it. If you go to assess your patient with this thing, if they have a balloon pump in, you're not going to be able to listen. You're not going to be able to hear or heart tones or lung sounds. So you have to put it in standby. So you simply press the standby button. It has an automatic alarm. If it's in standby for greater than 2 minutes, it'll start alarming at you. It'll notify you. So hit standby, oscillate your lung sounds, oscillate your heart tones, hit start. That also is a nice thing about it is it woke him up. So if you're oscillating lung sounds, you have to put it in standby. Another nice thing about that is it'll also allow you the opportunity to see what happens to their blood pressure. How much they're relying on the pump to assist their blood pressure. You'll typically see their heart rate go up, your blood pressure will go up, and then as soon as you hit start, it'll all go back down. So it's a nice thing to watch out for. There is also a button on, right there, the print strip button. For us on the flight team, if we're flying a balloon pump patient, all our blood pressures need to be monitored off this. If you're transporting these patients, like I mentioned, the mean arterial pressure and the diastolic augmented pressure, those should be documented. I would highly encourage you to document those because that's what you probably treat your parameters on. So watching those in your print strip. You can go into the menu and set it to print every 15 minutes, which is kind of nice too. So those are a couple of things to point out for the pumps. Hopefully when you get to your clinical rotations, either in CC or SI, you'll be able to see one of these. So, questions on the balloon pump? I don't think those are kind of the key points. I'm trying to think if I missed anything on the balloon pump. I did, I apologize. A couple other devices in regards to pillows. So this is another left ventricular assist device similar to the balloon pump. It basically helps decrease afterload. But the nice thing about this is it actually provides cardiac output. So if we've kind of talked about the cardiac output of being about 3.5 to 5.5 based on the book, what that little sheet told you. These catheters actually provide a cardiac output of about 2.5, which is kind of nice in a heart failure patient. That's an old fellow. So this little quick video, I'll just play this. Maybe you guys have seen this. You can go to their website and check it out. They have a lot more information. But this gets placed into a femoral sheath just like a balloon pump would. It's a pigtail catheter that actually sits in the left ventricle. There's an inlet that's in the ventricle here, and you'll be able to see it here, where it actually has a propeller-like system that pulls blood in and then ejects it in the outflow port distal to the aortic valve. So this catheter it says is a 2.5, and what that 2.5 indicates is like the maximum flow they can get with that catheter. So they can get a maximum cardiac output of 2.5 with that catheter. They have some that they'll use intraoperatively in the OR that are 5.0. Those are temporary. They have to be used in the OR only. So they can get about 5 liters, 4.5 to 5 liters of output with those catheters. And they've also come out with a CP catheter, which is kind of a kicked up version of 2.5 that can get probably about almost 3 liters of cardiac output. Which is kind of nice if you think about we're shooting a cardiac output on a patient that has an infarct and their EF is 10 to 15%. We hope it's going to improve because it was an acute event. And their initial cardiac output might be 1.8 or 1.9. We put this catheter in there, it helps with their output, allows our myocardium to relax a little bit and maximize the potential of outcome. LVADs, you guys have probably seen these a couple times as far as health failure aspects of things. You've probably been through the class on the LVAD a couple times. I just want to put those in there in regards to that, what they're doing. So you have your outflow graft, this attached to the left ventricle, you have your little pump. You guys got a couple patients in Altoona that have these, don't you? A couple of Ankeny? Yeah, there's quite a few in the morning. If you haven't transported a patient with an LVAD, you will. It's just a matter of time. So, big thing with these patients, it's all implanted. They'll have this percutaneous lead that comes out in their abdominal wall. And they'll have a nice upside over it that's plugged into their command module, their little computer. I think I got a picture of it here. Oh, that's a propeller system. But it comes out to a little computer. It shows you how many revolutions per minute there are, their flow and everything else. They have batteries, 2 batteries. The batteries last about 12 to 14 hours roughly. So that's kind of important to know as far as timing wise when you're transporting these patients. There's really not much to do with these. You kind of let the pump do itself. I did hear that our LVAD coordinator at Mercy said that they used to always say don't do CPR on these patients. Well, they've kind of retrograded that to say, yeah, if you need to do CPR, which I was kind of caught me off guard. So
So you are now
So you
supposed to
do
do that?
CPR?
yeah, you can if they're completely out and they're in cardiac arrest, you can do CPR, I guess. So
I thought you would.
Would it be pertinent to try and see if I can just add a battery or something?
yeah, absolutely. You
It's a
can,
problem.
if the module is alarming, yeah, absolutely check the module and see if it's alarming and fix those things. But if they're, apneic, unresponsive, and their pump's going, and there's not much, they're dead. So, are you gonna make them more dead? So looking at that aspect of it, who's your best resource for these patients?
The patient.
Patient, absolutely.
They got all this instructions.
Absolutely. Get their go bag. They'll have their little black case with them. Grab their case. You're not going to probably be able to get a blood pressure the normal, non-invasive fashion. You'll have to Doppel it. Doppel a blood pressure. You're going to get a mean pressure. So it's typically 70 to 90. If it's a low mean, if you're getting a mean in the 60s or something of that nature, what do? Give them fluid. They're volume dependent, so they need the volume to make sure the pump's going. So give them some volume, see if that helps. So, biggest problem with these patients is bleeding. GI bleeding is a huge problem with these patients because they have to be anticoagulated, so they're high risk for GI bleeds. So those are big things. Clots, kind of rare, but they can shower clots in them as well. They're kind of rare.
Their vasculature usually pretty good still. I mean, you get an IV pretty easy.
Typically, yeah. Usually it's not too bad. It's usually not too bad. It can be tricky, but any patient that has advanced heart failure and is chronically ill is always a trick, so it can be. ECMO. We'll talk a little bit about ECMO. I think that's part of this whole lecture stuff too. Huh? Is it? You guys haven't talked about that yet. The advancement of ECLS and ECMO, many days I kind of wish I was still back in the unit because this is the stuff that when I was up there I always wanted to do and take care of, and now we do it all the damn time that I don't even take care of those patients. I shouldn't say all the time, but frequently. So there's two different modes. There's VA, or venous arterial, and VV. The easiest way to kind of think of it, and the way I can always look at it, is VA basically means we need to fix the heart and the lungs. VV is we just have an oxygenation problem. So we just have a lung issue. So with VA, we have increased pulmonary arterial oxygenation, bypasses pulmonary and decreases pulmonary artery pressure, provides cardiac support with this as well. So they're cannulating an artery and a vein to basically bypass the heart and the lungs, in essence. VV, what we're doing is we're simply, it's venous, so we're pulling the blood out of the vein, oxygenating it, and putting it back into the vein. So we're kind of bypassing the oxygen functionality. So if you think of it in the aspect of this, if someone goes to open heart surgery, they get placed on VA. That's a bypass. If someone has a raging case of influenza and their lungs are crap, and we can't oxygenate them despite whatever bed settings we have possible, all these other tricks that we can try to do to improve their oxygenation, they get placed on VV. So we've actually had a few cases at Mercy that were actually trauma patients that had really, really bad pulmonary contusions. And pulmonary contusions can kill people because of their poor oxygenation. That they got placed on VV ECMO for 12 to 36 hours and they actually had great outcomes. Where if they hadn't, they might have, 10 years ago, probably would have died. So, which is fantastic. Indications of acute respiratory failure are septic shock. The H1N1 is where we saw a lot of this trend of evidence to support ECMO use with pulmonary disease. Bridge to transplant, so if a patient comes in with really bad heart failure, or lung failure for that matter, I suppose, but typically, lung failure, they get put on VV ECMO. So Murray score, this is some different factors they calculate out. There are some case studies done in Europe with the regards to influenza cases, H1N1 cases specifically, and they looked at Murray scores in regards to putting them on ECMO. This is what they're looking at. So the score, basically, your score looks at your PaO2, your FiO2 ratio on 100%, your chest X-ray, your PEEP, and compliance. So your compliance basically on the pulmonary side of things. And if they have a Murray score of 3 or 4, that's when they're going. So your PaO2 divided by your FiO2. So the way to look at that is if I have a patient that has if I draw blood gases on us right now, our PaO2 is probably 89, 90, 100. If you put me on a non-rebreather for 15 minutes, my PaO2 is probably going to be like 250 or 300. Just be something crazy. And if you divide that by the FiO2, well, we're going to be really, really high. So the sicker the patients, they're on a high FiO2 delivery, and their PaO2 is still crap, they get placed on. There's the ones that need that treatment. So, in a high PEEP greater than 15, they'll get that too. ECMO contraindications: non-recoverable cardiac disease, respiratory neurological disease. Someone has a big old head bleed, we're probably not going to put them on ECMO. Other things they look at: advanced liver disease. These are some of the parameters that they looked at in some of the studies. Unwitnessed prolonged downtime with cardiac arrest. So if these patients suffered a severe anoxic injury, brain injury, we're not going to put them on ECMO. And that's actually a lot of that. If they have a patient that goes into cardiac arrest and we get return to circulation and they don't have any EKGs changes on their 12 lead, they probably won't take them to cath out until we know there's functional neurological something there to see if they have coronary artery disease. Contraindications: severe PH, so right heart, left failure, cardiac arrest. VV ECMO does not provide hemodynamic support. So VV ECMO is simply bypassing the lungs. You're basically just oxygenating the patient with VV ECMO. It does not provide any cardiac support. These dual lumen catheters are huge. When they put them in VV ECMO, they put them into the IJ. I don't know if they can do some things, but they'll do IJs or they'll do femorals. It's not uncommon to see patients that are on VV ECMO ambulatory. They can be up walking around without a problem on ECMO. So I had a patient years ago, those were the H1N1 stuff in the unit, sick gal. Couldn't oxygenate. We actually, at that time, weren't doing a lot of ECMO at Mercy. Sent her Iowa City, and she was actually, they cannulated her, put her on VV ECMO, and she was actually walking around Iowa City on ECMO in the unit. So it can happen. We've actually done it at Mercy too now, that we've done it more frequently. Goals, so the goal is they usually try to get 50 to 80 mils per kilo per minute as far as the flow. Stuff that you really aren't going to need to know transport-wise, because if we're transporting someone else on ECMO, you're going to have a perfusionist over there. Would I say in the near future, 5-10 years, would it be possible for us to be, and I say us globally as far as EMS community, transport patients on ECMO without a perfusionist? Absolutely. I would not be surprised if that's the case. Pump, it all kind of depends on how you're setting it up as far as whether they're pumped, as far as the oxygenation and stuff like that. They can warm the blood. Has a warming nature of it. You can do a mixed oxygen delivery, so you're not necessarily delivering 100% FiO2. You can do a mix it with some medical air, so it might be a little lower based on blood gases. What they do, since we're oxygenating the patient, we don't put them on typical vent settings. We basically let the lungs rest. You can almost kind of think of it as, what do we do if someone has a massive MI? We try to let the heart rest. So by putting them on ECMO, we're basically allowing the lungs to heal. So have you guys gone over the vent chapter yet for this stuff? No? All right, well, typical vent settings as far as tidal volume is going to be about 6 to 8 mils per kilo. So here we're talking about 1 to 5 mils per kilo. It's quite a bit. I mean, normal, and that's all it's all based on ideal body weight. So typically, you know, for me, my ideal tidal volume or at probably 6 mils per kilo would probably be about 550 roughly. That's a ballpark number. So if you were to change this now, we're talking about giving me a tidal volume like 100. And that's infant size as far as how much volume, 150. So that's pretty minimal. Change the rate to 10. Usually you never would have a vent setting less than, in my mind, 14. But rate of 10, PEEP of 10 to 14. And the 10 to 14 of PEEP with that low tidal volume was basically just to keep the alveoli open. Yeah. Blood products, albumin, LR, don't give maintenance fluids. Just monitor the volume. Again, blood pressure, not 65. Hematologicals, stuff that you're looking at, labs, watch your hemoglobin, watch your platelets, correct INR, fibrinogen, watch for the bleeding. These people aren't anticoagulated. The less is more. The less we have to anticoagulate them, the better off they are. It just decreases the risk for bleeding and complications. Nutrition's huge. You guys, in critical care setting, our dietitian used to always get them on butt because when are we going to start feeding your intubated patients? It's huge for the body because it can actually decrease the chance for stress ulcers and stuff like that in the GI tract, and it actually helps a lot with healing. There's a ton of evidence in regards to internal feedings. So getting tube feeds and stuff like that started sooner is better for these critically ill patients. We used to have physicians, one physician specifically that says, well, the patient's 600 pounds, they don't need to eat. Yeah, they do. Their body still needs nutrition. They're going to start eating themselves internally, you know. Complications, no, not talk about that. Bleeding is probably the big thing. Stroke is always a risk as well. Infection's huge. Infection's always a big thing with these patients because they got a big old garden hose stuck in their vasculature. The sheaths that they use are about the size of your pinky. If you think about as far as the lumen size that they're using, they're huge. Cardiac arrest. This is a big thing. If you guys read the GEMS article, like in December, I think it was December, it was published. Yeah, and Dr. Yiannopoulos from Minneapolis is doing a lot of this. The eCPR or the ECMO CPR. And, we've actually had a case of this. Dr. Terry actually had a podcast and stuff like that with some of the physicians in San Diego. What's that?
He's out there right now.
Yeah, he's at some conference or something like that. Yeah, he said. So every Wednesday, like on the evening months, we have for the flight team, we have like our little case study conference or training. So he sent me a text message last night. He's like, "Hey, sorry, I'm not going to be there." And of course, he's sitting on the beach and it's like, thanks, Doc. Hammer. Yeah, probably. If not working on it, having seafood, feeding the seagulls. But basically what this does is if you have, that 40-something cardiac arrest patient that's refractory PFib, they shock you, you give them all the drugs, it doesn't do anything. Well, we all know the drugs really don't do anything anyway. What they've found is they've actually had some decent outcomes with putting them on a Lucas device, cannulating them, putting them on ECMO, and letting the body heal a little bit while they're in ECMO. And or taking them to the cath lab with a Lucas device on, cannulating them, and then shooting coronary arteries. What they're finding in a fair amount of these cases is that they have like a left main occlusion or something that it's a treatable thing. I mean, if they get that artery opened up, they have decent neurological outcomes. So there are some things going on. We're trying to work on something at Mercy in regards to like a shock protocol where some of these facilities around the country are actually saying that, hey, Altitude is bringing in a patient that's 45 years old and they're cardiac arrest and they've been shocked 6 times and their end title's 45 and, they're set. Everything other than the fact that their heart's not beating looks okay. And they have these rooms that they're like, all right, fine, we'll wheel you in here. And they have like everyone prepped and dressed and you slide them inside the patient over, keep Luke's device on, they start cannulating them for ECMO in the ER. If you look at Paris, France, they're doing this crazy stuff out on the streets. The EMS system's a little bit different, but Huh?
The one doctor from Minnesota has got his own car that he's chasing after the.
Yeah, Dr. Yiannopoulos.
Yeah.
Yeah, he's kind of a unique cat. I don't think that's the best way to do it, but I mean, he's having some decent outcomes, and if he's willing to put forth the effort, then fantastic. I mean, they're having good outcomes. I'm not going to fault him for doing what he's doing because he's saving people's lives. But eventually, I think this will be more common practice, especially in our setting. With our two health systems that are here and the capabilities that both of them have, I think this is going to be more common. FlowTrack, I had a slide up there of the FlowTrack, which is kind of cool. It actually monitors volume status. So a lot of times we're doing less invasive monitoring to watch volume status. They actually have sensors that you can put on the fingers, almost like a pulse ox, that monitors volume status and perfusion. So they also have sensors they use a lot of times in the PICU, that they put a sensor on their head, and then there's one on their kidneys that monitors perfusion as well. So it's kind of interesting stuff, but it's there. With these patients, pressors, think sepsis, bleeding, cranial condition, these are all things you gotta watch out for. Native lung function, certain feather loss, decreased feather. Yeah, so I mean, a lot of stuff with ECMO is pretty simple. I'm not going to go into a lot of this stuff here. VA ECMO. So VA ECMO is going to be shock despite volume. So if you think of our cardiac arrest patient that gets to the lab, you get a pulse back, they have a big OMI because you can see it on the EKG. They get their artery opened up, they're on a ton of pressors, they're on a balloon pump, and they're still crumping. They can get put on the VA ECMO. And basically by doing that, we're taking the heart function completely out of the equation. Now the heart can just relax and do what it needs to heal, and see if we can, either their heart function improves, or if it doesn't improve, then it's all right. Do they wake up? And if they wake up, then it's okay. Do they improve in a couple days and we get them off ECMO, or is it now we have to bridge them to an LVAD? How bad is their heart function? Do they stay on ECMO for a few more days, or is this a patient that has to have LVAD placed, or do they need to have a transplant? So those are the things that they kind of look at in regards to VA ECMO. There's anaphylaxis, peripartum cardiomyopathy. So we've had a few cases of that where they have peripartum cardiomyopathy, so pregnancy-induced basically cardiomyopathy. They go into really bad heart failure and get placed on ECMO. Hypothermia, drowning. With the hypothermia and drowning, it's a great way to, if they're in cardiac arrest, that's the whole thing of you have to be warm and dead, is they can do two things. They can warm the patient up, because the best way to warm a patient up is intravascularly with fluids. So if you can take the blood out, warm it up, and put it back in, it's going to warm them up faster than us trying to put like a bear hugger or blankets or anything of that nature on. So it improves that fashion, and then also oxygenates them as well. Aortic dissection. So if they have a big aortic dissection, severe aortic valve regurgitation would not be patients that we want to be putting on VA ECMO. Drain from the venous side, return to the arterial side, bypasses the lung. Total blood flow and ECMO circuit plus LV injection. So basically what you're doing is your blood flow is compensated by whatever the left ventricle contracts, but then also the flow of the pump itself. So you're improving your cardiac output. Nasomergen. Yeah, you can defibrillate them, correct electrolytes. So if they go into VFib and they're on ECMO, shock them. That's the other thing with like the LVAD. If they have the LVAD, the patient can be in VFib, VTAC, they can sit talking to you. Well, if you think about it, because the pump's just pumping. Same with this patient. I mean, this patient's on VA ECMO. If they're awake, they could be talking to you. Typically, they're not awake. Typically, they're intubated and sedated. But theoretically, they'd be able to talk to you because they're still confusing. The pump's familiar in your form, so they're still confusing. Hypertension. stuff we probably really not have to worry about too much, but it gives you some information regarding ECMO. What else? Questions? And every one of you, I am done with cardiology for the month. Right? Hemodynamics, I mean, we don't do a lot of it. I mean, they do a little bit of it in the hospital, but not too crazy much of it. The units, hopefully when you do your clinical time, you'll see it. You'll probably see more of it. Where are they doing clinical time? Everywhere? Yeah. So if you're doing clinical time, you'll probably see it more so in the cardiac adult units. So the cardiac surgical intensive care, you'll see a lot of hemodynamics there because of the post-open heart surgery. They'll have swans in, so you'll be the best opportunity to see it there. The ICU, art lines, probably ICPs maybe, if they have a Bolton or ventricular. You'll see some of those natures as far as like the transducer, how to set them up, and troubleshooting them and what to watch for and things like that. Questions on any of this stuff?
I may have missed it before I came in, but for the arc pressure lines, is there a certain spot where they have to be kept?
The thermostatic axis. So we did this little transducer port right here is going to be kept in the thermostatic axis. So the fourth intercostal, right at the level of the heart. So mid-axillary. So yep, that's what we want to drive in. What else? Y'all done. Friday. This is a quick overview of this stuff. I mean, this is, you can dive into hemodynamics, monitoring and stuff like that, but it's a good overview. You guys learning something from this stuff? Yeah. Not me, but just in general. Good.